Okay, so we've waited a minute and we will get started. Good afternoon, everyone. I'm Chuck Friedman. I'm the chair of the Learning Health Sciences Department in the University of Michigan Medical School. I see a few names I recognize, but not too many. So it's terrific to meet those of you I don't know. We're not going to take time in this first part of the workshop to give everybody a chance to introduce themselves. I would love for that to happen, but we've got a lot packed in to about a 4-hour period today, and I want to be sure we get through everything without having to rush too much, especially with the all-important second part of the workshop, which is a group exercise. You will get to meet your colleagues in the group to which you are assigned, and I hope you will get to know those people a little bit as part of that exercise. So we set you an agenda yesterday along with two very important handouts for the group exercise. Let me ask now, anybody who either did not receive that email or for any other reason would like us to send you another copy, put your email address in the chat, and Kathy will send you another copy of these materials. So Kathy, what time would this have arrived yesterday? It was in the morning, Eastern time?
Yes, I sent it out yesterday.
Okay.
Along with the reminder.
Right. Okay. So if you don't have that message with the two attachments, then put your email address in the chat and we'll get you another copy. In terms of the plan for the day, the workshop is in two parts. From 1 o'clock till about 1:15, there will be a lecture discussion where I will present on learning health systems, what they are, what I think they are. You might disagree. We'll have time to discuss that. And that will take us through, as I said, about 1:15. Then we'll take a short break and, 2:15. And then we'll take a short break and resume around 2:30. For the remainder of the time, we will be involved in an activity where in small groups, you will design a learning cycle, which is a key aspect of what a learning health system is. Along with about 5 of your colleagues, we're going to create the groups randomly. And you'll be engaged in that activity in your groups for about 45 minutes, after which time we'll all come back together. Several of the groups will get a chance to present the results of their activity. And we will close after that and hope that you will have found this to be a worthwhile time allocated to your afternoon. So that's the plan. I'm not seeing any messages in the chat. So for the moment, at least, I'm assuming that everybody has the two documents that Kathy sent out yesterday. So that's very good.
I actually, Chuck, one person needed it and I sent it. They sent me a direct message.
Oh, okay.
Yeah.
Okay. Well,
Nope.
1 out of almost 40 is a pretty good ratio. I will now share my screen and we'll get into the presentation. Would somebody please confirm that you can see my slides?
We can see your
Yes.
Okay, thank you. All right, so let's proceed. This introductory presentation will be pretty much in two parts. In the first part, I will talk about what learning health systems are, as I said, kind of from my point of view. And in the second part, I'm going to answer a question that I'm sure if I hadn't tried to answer it, you would have asked me. And it's such an important question, it's going to take up a very significant component of the presentation this afternoon to start our workshop. And this is the question of what's different about this? What makes this approach different from other approaches? And I'm going to take this from three perspectives. One, which is discovery, the second, which is continuity, and the third, which is scalability. And as the talk unfolds, I will explain in more detail what each of those means. So let's start with a definition. And paraphrasing an old joke, if you ask 12 people what a learning health system is, you will probably get 13 definitions, including one that none of them likes. But I'm going to give you a definition that I'm going to use and that I think is a fair way and not too long a way of characterizing what learning health systems are. And that's what you see at the top of the screen, that health systems at any level of scale, we're going to come back to this concept of scale on multiple occasions, become learning health systems when they acquire the ability continuously, routinely, and scalably to improve health through discovery and implementation in some ways that mimics some of the points that were in my slide about what's different about this. Now, credit goes to the National Academy of Medicine, which was then called the Institute of Medicine, for actually coming up with this idea. It first surfaced in 2007 as a report of a workshop that took place in 2006. Since that time, the NIM/IOM has produced a whole series of books and monographs on learning health systems. And you can go to any, you can go to their website, as you see here, and gain access to PDFs of all of these books and monographs. And I very much hope that you'll take a look at these. Now, there is also a journal creatively entitled Learning Health Systems, edited out of the University of Michigan. I'm a close friend of the editor-in-chief. This journal is in its fifth volume now, and while you will find a lot of literature scattered around many journals on learning health systems, if you want to see a lot of literature all in one place, you can go to lhsjournals.com and find it there. You may have also heard this thing called learning healthcare systems. And in fact, that's the term that the Institute of Medicine used when they first advanced the idea. And I really do think that a much better term to use is learning health systems. And I think you can anticipate why that's the case. Calling it learning healthcare systems kind of underscopes it. By focusing only on the healthcare process, improvement of that as a means to make people healthier, whereas the broader term of learning health systems really brings into play all of the things that are done and could be done to make people healthier, bringing in public health, population health, personal health, and other activities. So I will be using learning health systems pretty much exclusively in the conversation today. Whenever I do a workshop like this, I discover people calling it habitually learning healthcare systems because that's probably what they heard when they heard about it for the first time and just keep using. I will not correct that, but I greatly prefer the term learning health systems. If you want to find a very concise rationale, expanding on what I just said, you can take a look at an article, a very short article that was published by Aziz Sheikh from the University of Edinburgh last year in Learning Health Systems. So another way to think about what learning health systems are is to think about anthems. And you can use your imagination and think about the learning health system army. The aggregation of people who really believe in this idea and imagine them on the march in a parade singing songs, and use your imagination and think about what songs they would be singing. Now, I have not put these to music. If you're so inclined and want to write some lyrics that match these titles and some music to go along with it, I would be very grateful to you, and in fact would be happy to give you a reward for this. No one has done this yet, but I hope someone will. The first anthem is Bring Us the Tough Problems. To my way of thinking, learning health systems are tailor-made to solve really, really tough, what might be called wicked health problems. And you'll see some examples of some of the work we're doing to improve against some really, really wicked health problems. Second, this sounds a bit more like a song title. A system problem needs a system solution. What this means is that wicked problems tend to be problems attributable to multiple causes, multiple factors, and complex environments, in other words, system problems. And you're not going to fix these problems by addressing only one aspect of what is causing this problem. A system problem needs a broader solution, a system solution. So that is the second anthem. And the third one I really like, 17 years to 17 months. And what this refers to, you, if you're familiar with this literature, is the pretty well documented latency between the introduction or the discovery of new biomedical knowledge and its widespread use in interventions and activities to make people healthier. What I believe and what others believe is that learning health system methods can shorten this latency by whole orders of time magnitude, from 17 years to 17 months, and maybe even 17 weeks to 17 days, and in the case of a public health emergency, maybe even 17 hours. So bring us the tough problems. A system problem needs a system solution. And 17 years to 17 months are the three anthems I think the learning health system army on parade might be singing. Music wanted, let me know. Now, zeroing in a bit more specifically on what learning health systems are, let's use our imaginations again and think about an inspector who arrives at a health system with the task of determining to what extent this health system is a learning health system. And like all inspectors, this inspector has a clipboard, and on the clipboard is a checklist, because that's how inspectors work in our business. And while there probably would be a lot of detail on this checklist, let me share with you 5 high-level things that this inspector, in my view, would be looking for. The first is, can this health system capture as data to learn from characteristics and events and context, everything that goes on in that health system? Does it have the capability to do this? And later on, we're going to call this capability data to knowledge, but we're getting ahead of ourselves. Second, once this health system analyzes these data and converts it into knowledge and grows to trust for various reasons, the knowledge that they have developed, can they make this knowledge available in useful ways to support decisions, and not just decisions by care providers, but also decisions by patients, decisions by patients' family members, decisions by managers and administrators. And we'll call this knowledge to practice if the system can, in fact, do this. Is there evidence that these activities, which can lead to improvement, are continuous and enduring through ongoing cyclic activity, or is this place kind of bursty? And when threatened with loss of accreditation or other economic or other crisis, it becomes a learning health system. But when the crisis is past, goes back to the way things were before. This is another thing the inspector would be looking for. here's this concept of infrastructure. Is there an infrastructure in place that enables all of these things to happen routinely and with economy of scale? In other words, they're not going broke doing this. And finally, the inspector will be looking for whether all of this is part of the culture. And by this, I mean, and what the inspector would probably be looking for is when the inspector talks to people in this health system and says, why do you do all this stuff? The most likely answer, if it's part of the culture, is I can't really tell you. This is who we are, and this is what we do. This is woven into our fabric as an organization. So this is another view of what a learning health system is, a health system that can do these 5 things to the satisfaction of this inspector. So this takes us to a kind of way of looking at the Gestalt of the learning health system. And I produced this by pulling keywords out of the items on the inspector's checklist. And you get kind of a Wordle representation here. Persons and people, learning, data, knowledge, rapidity, performance, continuous and enduring, cyclic activity, infrastructure, and culture. In a way, these are the concepts, the key concepts that learning health systems are made of. Now, I said that we are going to talk about scale several times today, and this is the first time this concept will come up. It's very important to recognize that learning health systems can exist at any level of scale, and moreover, that at whatever level of scale they exist, they do pretty much the same thing. This makes learning health systems what mathematicians call a fractal. When at different levels of scale, they function pretty much the same way. At the lowest level of scale, a single organization can be a learning health system, and you see a single hospital or health center depicted there. Networks of organizations can come together usually around certain categories of problems or disease domains to form learning health systems at the scale of the network. And you see a 6-institution network depicted here. States, provinces, and regions like Michigan depicted here can become a learning health system. And there are examples of learning health system at state scale in Michigan. Nations can become learning health systems at national scale. And here you see Switzerland, which is one of a few nations at the moment that has national level learning health system initiatives deployed within it. And then there are those who can hope and dream that someday there will be a global learning health system. And I think, and we can discuss this a bit if you want, that if ever there was a clarion call for a global learning health system, we got this from COVID-19. So what do learning health systems do? How do they engender improvement? And they do this in a way that is not new. This is the idea of learning cycles or improvement cycles, or more generally, a cyclic approach to improvement, which is an idea that has been around for approximately 100 years. Nobody knows who originally came up with or originally implemented this idea, but it is certainly not new. The learning health system has a particular, if you'll excuse the pun, spin on this cycle. And I'll review it very briefly here and then give you an example. In learning health systems, in learning health systems, a cycle begins when a learning community, a multi-stakeholder learning community, forms to achieve improvement with respect to some health problem of interest about which the members of the learning community are more than interested. They are probably passionate to solve this problem. The cycle then begins after the community forms with the process that we call practice or performance to data, where the community takes it upon itself to study what happens now. What are we doing now? And the way they do this is by capturing key aspects of practice as data, amenable to analysis, and moreover, they will identify the metrics that will be used to track progress, and at this point, take a kind of baseline measurement of these metrics against which later progress can be measured. I don't know why I keep doing this. Then as the cycle proceeds into its next stage, which is data to knowledge, the community assembles this data into a analyzable form. And if the data are coming from multiple sites, of course, this could be a non-trivial activity. And in fact, as you probably all know, if the data are coming from one site, this could be a formidable activity, making the data consistent and thus analyzable. Then the data are analyzed. This generates new knowledge and possibly insights into how things might improve, as done internally by the learning community itself. Now, it's probably the case that any problem important enough for this learning community to get passionate about has been studied by others, and therefore there is external evidence in journals and from other sources that also can be brought to bear to help the community as it goes into this next stage at 12 o'clock on the cycle. It comes together to interpret the results. What have we learned from the internal and external evidence in combination? And can we cull from this enough of an idea of something that might be done to improve against this problem with that is promising with enough confidence to actually begin to design an intervention? And if so, the cycle moves into its next phase, which is knowledge to practice or knowledge to performance, where one or more interventions are designed. And this may be one intervention, or it may be multiple interventions, which create a kind of interventional experiment, or maybe choices that different participants in the learning community can pursue. After that, action is taken, these interventions are implemented, and this swings the process around to the beginning of the second cycle, where new practice, because the system has changed, is captured as data. The metrics are measured again to determine not only whether there has been progress, but what activities, what practice changes are most closely associated with a positive change. And these new data, this new configuration assembled as analyzable data, then triggers the remainder of the second iteration of the cycle and so forth. So let's now take a look at an example to make this a little more concrete. And I'm going to use the example that, in fact, you're going to be using in the case study that will follow the first part of the workshop. So let's suppose a problem of interest that to a passionate learning community, and you can understand why a group might get passionate about this, is the problem of elderly people in nursing homes falling and seriously injuring themselves. I think we're all familiar with this problem. And in this example, the first stage of capturing practices data would engage the community and looking at, in the nursing homes participating in this learning cycle. And this could be any group. This could be all the nursing homes in a state or region. This could be all the nursing homes owned by a particular company. This could be a self-organizing group of nursing homes that just wants to improve, but there will be an identified group of nursing homes participating in this. And in this first stage, they will capture practices data. They will figure out what happens now and what is the fall rate and severity and any other outcome metrics they choose to measure. Once they have this data, they will assemble it from all participating nursing homes in a form amenable to analysis. They will analyze the data, probably identifying practices that associate with lower fall rates. This will be a correlational result, which when analyzed will have to be understood as such. And this will be combined. These results will be combined with external evidence, which in this case is abundant on this issue. And when the community comes together at 12 o'clock to interpret the results from both sources, they will ponder based on what they learned from the internal discovery process and what they learned from the external evidence, what interventions are indicated. Then they'll design these interventions. Who receives them? How will they be implemented? Will we do an experiment? Will we do this one way, or will we do this multiple ways and maybe compare the results? Then after doing that, they will take action. They will to change current practice in whole and part, in some places and not others, in some ways and not others. And the effects of these actions will result in a changed system. What happens now, and this will be documented in the first stage of the second iteration of the cycle as it swings through to performance to data. And the fall rate and the severity and other metrics will be measured to see if there was improvement and what practice changes are associated with that improvement, and it will go on from there. Now, the summary point here is that better health requires, in the view of the learning health systems concept, these complete cycles. And I'm showing this to you to contrast it with two other conditions that I believe are not as effective and beneficial to improving health as this full cycle approach. One is what I and most of my colleagues at universities were taught to do in graduate school and have done for a lot of our careers. We collect some data, we analyze it, we thus converting it to knowledge, we put that knowledge in a journal, and then we go back to here, and we collect some more data, analyze that data, perhaps about a different problem, and we publish that in a journal, and so on and so forth. And that gets us promoted and tenured and maybe even famous, but we have to ask the question about whether directly that makes anybody any healthier. We do this on the assumption that there's somebody here who is going to take what's here and put it into practice, do the K2P thing. But too often, and I think we can all appreciate this, nobody's home here. Or if they are home, it takes a while for this to happen, for the information, the knowledge in the journal to wend its way into practice. And to my way of thinking, at least, you were looking at one of the main reasons for the 17-year plus or minus latency between the creation of new knowledge and its widespread implementation. Now, another contrasting model is the full cycle, but the full cycle with gaps. And the full cycle with gaps is an attempt by many organizations to complete cycles. But as we will discuss later in more detail, instead of doing it with the same learning community following through the whole cycle, different groups of people in the organization do different components of this, leading to gaps and the need for handoffs. And every Michigan football fan knows when there are handoffs, there can be fumbles. And this is another problem that the learning health system approach seeks to address through this learning community approach, which uses the same group to follow the cycle around and control the gaps. We'll return to this point. As we bring the first part of this talk to a close, I'm sharing with you some examples of learning health systems that are at varying levels of maturity. And I hope this illustrates that this is an idea that is taking hold and growing. Several single organizations are either have become or are in the process of becoming learning health systems using the term, perhaps interpreting it somewhat differently. I would single out 3 health systems, Intermountain, Geisinger, and Mayo, as health systems that today, were they inspected by our hypothetical inspector, would cause all 5 boxes in that checklist to be checked. And many others through their clinical translational science institutes predominantly are well along on the road to becoming learning health systems. The networks are popping up faster than pretty much anybody can keep track of it. There are several networks started by PCORI, including one based at Cincinnati Children's Hospital called Improve Care Now, that really is a model for them all. PedsNet, based in Philadelphia at Children's Hospital of Philadelphia, is a national pediatric learning health system that calls itself that. CancerLink, started by ASCO, the American Society for Clinical Oncology, and our former dean, Alan Lichter, is another example of a network. NIH has gotten into this game with the EpiNet early psychosis intervention network that, as I understand it, our institution at Michigan participates in. And there are several initiatives out of the Agency for Healthcare Research and Quality relating to learning health systems, including a training program. There are examples of learning health systems at the state and provincial region in Canada and in the US. I can cite Switzerland, the UK, Saudi Arabia, and the Veterans Health Administration in the US as national scale efforts. And then someday, perhaps stimulated by the tragedy of COVID, we may evolve to a global learning health system. And here's an example of what's going on in England, National Learning Health System, in the UK, I should say. A national learning health system stimulated by a group called Health Data Research UK is bringing this about through what they call the Better Care Partnership. And what you see here is something that looks a lot like what I showed you. And they call it a conceptual framework, a Better Care Loop for learning health and care systems. So this is just an example of what's going on in some of these countries. I'm going to stop here, take a pause, stop sharing my screen for the moment, and give people who have questions an opportunity to ask. Please raise your hand and I'll recognize you, and unmute yourself and fire away. Gregory.
Chuck, thank you very much. Can you comment on whether you view like the Blue Cross Blue Shield quality initiatives as one of these or something different, and how it's different?
No, I do view them as learning health system efforts, very much aligned. And that's why one of the reasons I said there are examples of this in Michigan, but I will make the point later that that effort lacks one key element of learning health systems, which is infrastructure. You'll pretty much, each of these collaborative quality initiatives operates as a tub on its own bottom. And that points to a lack of this infrastructure component, which is very, very important for scalability and economy of scale. But absolutely, yes. So now we swing into the second part of the talk, which is about learning health systems, how they differentiate themselves, how they are different from other approaches. And there are 3 such differentiators that I will talk about. The first of these is what I call embraced uncertainty requiring discovery. And remember I said earlier, hang on one second. Remember I said earlier that system problems are complicated problems. And when you look at a complicated problem, it's very, very unlikely when you take stock of this problem, you're going to know what to do. System problems are complicated. They have multiple causes, and what to do to address them isn't going to be clear. So at the outset, the community really doesn't know what it's going to do. And there are, when you think about how this learning cycle unfolds, there are open questions at each stage of the learning cycle. In the P to D stage, the community is asking, what's happening now? In the D to K stage, the community is asking, well, how should we, what knowledge can we generate to tell us how to change? And in the K to P, they're asking themselves the question, how should these changes be implemented? So the community all through the cycle is asking questions and seeking to discover the answers. And a very important corollary to this is the observation that the learning about where the learning cycle should start. It's very important for a complex problem for which the solution and the best way to proceed is unknown, for the cycle to start down here at 5 o'clock and not up here at 12 o'clock. If you start at 12 o'clock and basically say, we're going to start off by doing something, this will only happen if the community has been told what to do by some higher power, which can take many, many forms, or if the community has made what we might call an evidence-free decision. They've just got together and deliberated and decided this is what we're going to do based on no evidence, either external or internal from their own analyses. However, if the cycle starts at 5 o'clock, then the community collaboratively discovers what to do. You start here with performance to data by trying to understand what's happening now. That's the starting point in collaboratively discovering what to do. So there are a lot of scenarios that depict the starting of a learning cycle at 12 o'clock. And one of them, I think we've all been there. We're in some organization and we are told that the leadership has decided to hire miracle consultants. And there are lots of consultants around who consider themselves to be miracle consultants, whether they use that name or not. And their program will be implemented to reduce falls. This is what you're going to do. So this community is charged to work with miracle consultants to implement their magic solution, whatever it is. But contrasting this, starting at 5 o'clock, which is the learning health system approach, the verbiage might be, well, everyone's concerned about the rate of falls. We're more than concerned. We're passionate about solving this problem. And based on our own studies and the literature, we're going to develop and implement a plan to make things better. So this idea of starting at 5 o'clock and not 12 o'clock and embracing discovery as probably the only way to find a system solution to a system problem is a first differentiator of learning health systems. The second is this idea of the multi-stakeholder learning community, which I've talked about previously, and I'm going to say a little more about now. This idea of continuity is that the community that discovers is also the community that implements. And it's illustrated that here, that the learning community does the green stuff. The learning community changes color as it were, and does the blue stuff. And the learning community changes color again and does the red stuff. Now, as this same community follows this whole cycle around, some members of the community will probably be more prominent and others less prominent. and they may draw upon resources outside the community to help them that will differ as the cycle progresses. But fundamentally, the whole cycle is in the hands of this learning community. And even when people drop into a lesser role, they are still involved, and what they say about what should be done still matters. Not this. This is that gap situation that I described before, where you have different groups doing each part of the cycle. Let's call the P to D group the program evaluators, and the D to K group is often called embedded health services researchers, and the K to P group are the change implementers or the quality people. And these groups may all be highly competent and well-intentioned, but they are different groups with different cultures who may or may not know each other. And it is very difficult to have a continuous fumble-free process going from P to D to D to K to P, when it is these different groups from whom and to whom the process needs to be handed off as the cycle continues. So this is this all-important continuity, and it comes about through this continuous presence of the learning community. So you got to start here, not only at 5 o'clock, but you got to start with the formation of a learning community. And what do we mean by a learning community? Well, it's a collaborative. First of all, it's multi-stakeholder. You need every interest group represented in the learning community. I like to think of a learning community as kind of like a stable atomic nucleus. And if you take one neutron out of it, it goes unstable and basically falls apart. A learning community is the same way. Everybody's got to be at the table. They're pursuing a shared goal, that learning, that health problem of interest, whatever it is very specifically defined. And the work of the learning community is typically fueled by passion, as I described earlier, to achieve the goal. This is a collaborative community. Strategies are co-produced, and nobody takes control. No one group or no one person takes control and says to the learning community, this is how we're going to do it. Everybody owns the process and everybody owns the solution, which means the leader must use facilitative methods. And as I mentioned earlier, no group can be allowed to dominate if a learning community is going to function effectively. Improved Care Now is probably the nation's sterling example of learning communities and how they function. I've learned a tremendous amount from these people. They've been at this for a long time. They are working with other networks to convert them from research networks into full cycle learning networks. And by the way, I would encourage you to go to their website and watch their video. It's truly inspirational. And they let their results do the talking. They focused initially, although they've gotten involved in other diseases, on inflammatory bowel disease, and have a record working over a decade of enormous progress in increasing the remission rate of adolescents and young adults with this disease. We're working in Michigan on a really, really wicked problem. We're aiming, working with the Department of Emergency Medicine and many others in the environment to double the pathetically low survival rate from out of hospital cardiac arrest, and survival is defined by discharge from the hospital with good neurological function. And you can see the survival rate hovers around 10%. So if you want a wicked system problem, here is one. And it's a system problem because it involves stakeholders across the whole, what the American Heart Association considers to be the chain of survival. This effort now does have funding as part of a grant to the university from the American Heart Association. And we started by forming a learning community. And you can see the multi-stakeholder nature of the community in the panel in the upper right. It's a fairly large group, as you see from the meeting in the upper left, and it's active and participatory. And what you see in the lower right is that it involves survivors of arrests, and there you see a survivor with someone you might recognize as Brahmaji Nalamothu, who was the cardiologist for this survivor. And you see the survivor's daughter there. And you also see that this is not a problem that afflicts only older people. So learning communities. The third is infrastructure. And by infrastructure, I mean that there are shared services enabling scalability, and I'll talk about what that means a bit more in a moment, actually right now. So think about what a learning health system really is. And it's got to be more than just a collection of learning cycles. And what you see up here is a collection of learning cycles. And these learning cycles may enable improvement in each of these different health problems of interest, but they don't create a learning system if they function independently of one another. And just to get a general idea of what I mean by infrastructure, think about a city, a big city that is bisected by a river like Boston or London or many other major cities in the world. And if you want to get lots and lots of people across that river every day, well, one of the ways of doing it is to give everybody some wood, a hammer, nails, some glue, and I guess a few other things, and say, build your own rowboat and row yourself across the river every day. That's hardly an infrastructural approach. An infrastructural approach would be to build a bridge, which can be used by many, many people and many, many modes of conveyance, from pedestrians to trains in many cases. And that is an infrastructural approach, one resource providing a service that everybody can share and that meets everybody's needs. With that as background, you have to think about this for a second. A learning health system can be depicted this way. A learning health system at any level of scale, and this will be true of a network, of an institution, of a nation for that matter, will consist of multiple learning cycles. You see 5 depicted here, each addressing a different problem, operating under the aegis of its own learning community that shares a passion about that problem. But all of them are doing fundamentally the same thing, the green to blue to red, P to D, D to K, K to P thing, around and around. Some, by the very nature of the problem being addressed, are going to cycle more rapidly. Others are going to cycle more slowly. Because they're all doing the same thing, they all can be supported, just like with a bridge, getting everybody across the river, by an infrastructure that we term a socio-technical infrastructure, because it's not just about technology, it's also about people, it's about processes, and it's about policies. A lot of people think that technology is all you need, the right technology and EHR and a few other technological tricks to have a learning health system fueled by an infrastructure, but that isn't the case. Like so many things, it's as much about people as it is about technology. So the infrastructure that can support these learning cycles by providing services they share must be a socio-technical infrastructure. Okay, why is this so important? It's probably pretty obvious, but if you don't have this platform, and you kind of have these free floating cycles, each kind of doing its own thing, then every cycle requires its own stuff, its own agreements, its own technology, its own staffing, its own analytics, its own dissemination mechanisms, and there's absolutely no economy of scale. I'm hardly an economist, but I do know without an infrastructure, the cost of doing 10 of these cycles is going to be exactly equal to 10 times the cost of doing one. And that's not the way to get to the promised land here. With a platform, such as I described, a socio-technical infrastructure supporting all of these cycles, there's big economy of scale because they share services, and the cost of 10 cycles will be far, far less than 10 times the cost of going one. And moreover, at the margin, if you have 5 cycles, the cost of adding a 6th will be relatively low. Another aspect of economy of scale. So I really think that infrastructure particularly is what differentiates learning health systems from a lot of other approaches to health improvement. And this isn't criticisms of these. I'm just pointing out how it's different. So lean, freestanding PDSA and PDCA cycles and proprietary approaches from places like Miracle Consultants do not have this infrastructure. And by this, I mean a learning health system is a combination of these community-driven cycles and a supportive infrastructure. Increasingly these days, infrastructural components are being developed, and that can be shared, furthering the economy of scale and allowing learning health systems to scale up, to grow from lower levels of scale to higher levels of scale, smaller networks to become bigger networks, networks to come together to form regional learning health systems, regional health systems coming together to form national ones. So this is an important aspect, not only of how learning health systems can have economy of scale in and of themselves, but also how they can scale up. Okay, so what does this infrastructure consist of? Well, to explore that question, let's take a look from the top down into this diagram. In other words, put yourself on top of this diagram and look down in this direction, and what you'll see is something like this. You'll see these co-occurring learning cycles. You'll see the ring, and what I'm showing you here, and we won't go into this in a lot of detail, just enough to kind of give you the general idea, are 8 kinds of services arrayed here along the infrastructure platform to correspond to the piece of the learning cycle they primarily support. So over here at 5 o'clock, where the learning communities form, you see infrastructure about organizing, starting, and maintaining and supporting learning communities. None of this is really technology. This is people, process, and policy. Then as you move into P to D, the infrastructure can provide methods and support for capturing, identifying, and measuring performance and performance changes. Over here, we get into a more technical service about representing health information as computable data. Here we see one focused on policy, providing infrastructure for providing and governing access and use of data, and so on and so forth, all around infrastructure that enables learning communities to enable and promote performance changes. They may not know how to do this themselves, but can get help from implementation scientists and specialists and others to assist them in doing it. So this is what the infrastructure looks like. And the good news here, as I elaborated, I'm blocking on the word, but said before, there are a lot of open source infrastructure components already available that entities hoping to build a platform can just pick up and use and adapt for their own purposes. And here I've arrayed some of these. I'm pleased that our own staff here in the department has developed a guide that anybody can use to operationalizing a learning community. There are techniques that we are using with out-of-hospital cardiac arrest, called, for example, deliberative dialogue, to kind of get the most efficiency of process from the learning community. There are tools that are more technological, such as what David Hanauer here has developed as an open source tool called Immerse for representing health information as computable data. Smart IRB is a infrastructural solution to help provide and govern access to and use of data, particularly useful in networks. There are a number of technological solutions for sharing and analyzing data. And another example of something developed here, the knowledge grid that supports making knowledge computable and shareable and delivering advice to applicable users. In other words, people wanting to build learning health systems and build them with infrastructure don't have to start from scratch. So this brings things to a close, and we'll have 15 minutes for questions and discussion. Coming to a close here. To summarize, what are learning health systems? If you want to wrap it all up in a sentence, a little bit different from what I gave you at the beginning. Learning health systems improve health by marrying discovery to implementation, which drives further discovery, getting at this cyclical idea. And what makes the approach different? This is the same as what you saw before: embraced uncertainty, requiring discovery, multi-stakeholder learning communities, enabling continuity, and infrastructure, providing shared services, enabling scalability. A couple of papers, a little bit of a shameless self-promotion here that I can recommend to you. One is toward an information infrastructure for global health improvement. Another talks about how one might put evidence into practice in the era of learning health systems. And then I really would suggest, if you want to see a lot of good literature in one place, you can find it in the journal. So we're going to go into question and answer now. We have about 15 minutes for that. I hope I've stimulated some questions about which we can have a thoroughgoing discussion. But if we don't get to your question or it's something that occurs to you later, please feel free to write to me. If you write to me, I will write back to you. So I'm going to stop sharing and let's go now into questions, answers, comments, arguments, polemics, anything you would like to bring to bear on the discussion now. Raise your hand and I'll recognize you. Gregory again.
You can put me in the back if there are others. Actually, I'll wait. Take others and I'll come back. Thanks.
Okay, Jennifer.
Hi, thank you. I have a question. I'm wondering about implementing this on sort of a smaller scale within a department. I work in the orthotics and prosthetics department.
Mm-hmm.
Is that something that, Michigan Medicine is interested in and focused on? I mean, when you talk about like asking these big health questions, we're a super small part. So like our questions that we would ask that would seem like big to us, wouldn't actually be big to the whole health system at large, I would imagine. Where do you see a department like ours fitting into this, or is that not really what we're talking about here?
You can do these methods at, certainly you can implement learning cycles at any level of scale, including the one you talked about. What I would encourage you to do is not build out your own infrastructure on your own. If you're going to do that at your level of scale, you should try to find infrastructural components from other places in the institution that can give you support. We're working to move the institution toward a more robust infrastructure, which would put in place services that you could use. So yeah, I could see how, based on what some of the things I said, you might think that I was saying that don't do this unless you're doing it at the level of a whole organization like Michigan Medicine or something that looked like that big building I showed. But no, it can be done on smaller levels of scale, but you should be mindful about what kind of about do-it-yourself infrastructure if you're at that level.
Chuck,
Thank you.
Okay.
it's Linda Grosh.
Hi, Linda.
Hi, Jennifer. I wrote in the chat, so take a look at the chat because we're actually working. So OMP kind of falls under PM&R, Chuck. So she can work with Claire and I, and we actually have OMP on the agenda. So good news.
Okay, thanks, Linda. And PM&R is sort of within the medical school, the flagship department with Learning Health System Initiative. So I'm glad this connection got made. Michael?
Thank you for organizing this session. My name is Michael Avidan. I'm at Washington University in St. Louis. I have two questions. The first is, how does a learning health system deal with ethical challenges? Specifically, how do you test interventions without obtaining patient consent? And the second is, how does a learning health system overcome the challenge of establishing causality, where the best method for assessing causality is randomization? Do you try to build randomization into your methods in a learning health system? Thank you.
Thank you for those questions. So learning health systems pose an ethical challenge because the question arises, is this regulated research or is this relatively unregulated quality improvement? This dilemma was first propounded by Ruth Faden and Nancy Cass in work they did almost 10 years ago, basically saying we almost need a new set of ethical constructs for learning health systems because they're kind of quantum mechanical. They're not one or the other, they're kind of both. We don't have that new structure. So what individual institutions do to manage it ethically is put some things on the research side and some things on the quality side, making sort of common sense decisions. And sometimes this is part of a learning cycle that goes on one side and part that goes on the other side. And sometimes because of the nature of the problem and the governance of the institution, the whole thing goes on one side or the other. But when it's on the research side, it's under the aegis of the IRB and it's run like research. And when it's not, it's governed by the institution's own policies for governing regulation of quality improvement activities. Either way, this is not a casual, unsupervised undertaking, and whichever side of that divide it falls on, every institution I know of that does this respects their rules and regulations governing that activity. I'm among those who believes we need a new ethical framework, and we may get there someday. Great question. Second question was, I got so engrossed in answering the first question, I'm going to ask you to restate it.
Thanks. Great answer to the first question. The second question is, how do you overcome the challenge of establishing causality?
Oh, yeah, thank you. So as I said, oftentimes the result you're going to get from that first cycle is going to be associational. I'm among those who believe in methods of causal discovery where you can get you could make semi-causal inferences in many cases from observational data. So that's one way to approach it, but it will be observational data. The other, however, the other piece of this, however, is that external evidence that you bring in, some of which will come for randomized studies. And when you fold that in, to whatever extent you can't draw causal inference from the internal studies, you might be able to supplement that with studies that are in the literature, which are better controlled, but lack the internal validity of your own work. Now, additionally, and many places are doing this, on the implementation side, you can run experiments. And you can do a learning health system version of what Amazon does, running these A/B experiments in sort of an extreme case. But basically the idea is you implement in different ways and you compare the results. Now, whether you can do that in a fully randomized study, or whether you have to run a kind of quasi-experiment, depends on a number of things. But there's a second opportunity to do more rigorous comparative investigation on that knowledge to practice side by virtue of implementing different interventions and comparing the results and learning from their possibly different outcomes. Okay, I thought I saw another hand. All right, well, since there are no more questions, we will now take a 10-minute break. I hope you'll all come back. It's 10 after 2 on my clock, and we will all come back together. And when we come back together, I will explain to you in great detail what's going to happen in the groups before we actually put you into groups. So when you come back, we're going to have about a 15-minute plenary session where I will explain what you're going to do, and then we will put you into groups and you'll do what you're going to do. Okay, see you all in 10 minutes. Thanks very much. So now for the fun part. The fun part was not listening to me. The fun part is this exercise, at least in my opinion. Can you see my slides?
Yes, we can.
Thank you. All right. So we're going to take about 90 minutes for this session. We will begin with what we're doing now, introducing what's going to happen. This may not quite take 15 minutes. You'll have about 45 minutes, and that's typically what it takes to go through this exercise. And then we'll come back together for a full group discussion, which will largely be a comparison and contrast of what the groups came up with. So what you're going to be doing is designing many components of a learning cycle that is focused on preventing falls in nursing homes as a problem of interest. And I chose this because it's a problem either directly or indirectly of interest to everyone, and I hope you'll have a good time with it. So what you're going to do is you're gonna follow this cycle around in your design activity. You won't be designing every component of the learning cycle. There isn't time for that. And it gets a bit hypothetical as you progress on down. But as you'll see in a moment, or if you've taken a look at the exercise sheet, you'll see the specific things we've asked you to do. So in this case, we will soon create, or maybe we've created already, breakout groups of approximately 6 participants. These are created randomly. Your group will design many elements of a learning cycle to address falls in nursing homes. And I've already mentioned that a task instruction sheet and a recording sheet, 2 documents were emailed to you. And I've already asked you, I was going to put this off till now, but I've already asked you to put a note in the chat if you don't have this material. So I'm assuming when we go into groups, you all have both documents on your computers and available to look at. Now, this is the top part of the task instruction sheet, which is one of the documents you have. And you're going to, as I said, you're going to develop a plan for a learning cycle. And the instruction sheet has more detail and asks you to do some very specific things by way of designing a learning cycle. And you're going to be focusing on 3 particular aspects. Number 1 is the all-important formation of the learning community. Number 2 is the next step, which is capturing current practice as measurable data. And then number 3 will be a bit hypothetical in that we're going to ask you to make some assumptions about what you have discovered from your data to knowledge work. And based on that, begin to think about at least designing an intervention functioning as a learning community. If we've discovered these things, if we assume that we've discovered these things, what would we do in the way of an intervention? All of this will be clearer when you look at the task sheet, which provides literally step-by-step instructions that you should follow through in sequence. So when you get into your groups, begin by making quick introductions all around. Don't use too much time for this, but say who you are and what you do. And then after you've done the quick introductions all around, you got to make 2 choices. You've got to select a reporter, and this has to be somebody who can share their screen. You should all be able to share your screen, but be sure you can share your screen if you're going to serve as the reporter. If you get selected or volunteer to be the reporter, test out that you can share your screen by pressing the share screen button and see what happens. The group will also select a moderator to facilitate the discussion and above all to keep track of time. I have done exercises similar to this where the group got so engrossed in the first part of it, discussing who should be in the learning community and how these people will be selected and so on and so forth, that we were 35 minutes into the exercise and that's all they had done, even though they had gone relative to that topic into great depth. That's not the goal here. The goal is to complete the task. So I will ask the moderator, using whatever moderation skills you possess, to try to keep the group moving along so that you finish the 3 parts of the exercise in the 45 minutes. It's possible to do that. It's a bit of a perfect is the enemy of the good exercise. If it's good enough and you're reasonably happy with it, you can move on. So begin working your way through the task instruction sheet, go step by step, and that's very important because the steps build on each other. The recorder will, at the outset of the group's work, share their screen, And what they will share is the recording sheet. And as the group works, the recorder will be typing in to that form for everybody to see what the group has decided. And so as you proceed, you'll have all of the results of the group's work on the preceding tasks in front of you as you get to the next one. If you need help, this one I probably should have changed because we have 3 members of the staff here who will be working to assist you, Michelle Williams and Lisa Ferguson and myself. So if you need help, don't use the help feature. They're going to be moving back and forth between 1 or 2 groups. One of us is only going to be with one group. So if the staff member, either Lisa, Michelle, or myself are not there, we will get there soon. So Lisa and Michelle, if you've got 2 groups, move pretty rapidly back and forth. As I said, you have 45 minutes for this exercise. So we will gather as a full group for the last 30 minutes. Each group's recorder at the time we come back into a full group should be ready to display his or her group's work because the recorder will have been entering it all the way along. And when we get back into the full group, if we call on that group to share their results, should be able just to share their screen and use the completed recording form as the basis of that group's report.
Oh, there you are. You're back. Okay, I got worried.
No, I'm here. I'm here. I didn't leave. So Michelle, we're going to put you in a position of power here. Which of your 2 groups would you like to present? I'm going to make you play favorites here, Michelle.
Oh, I think they were both. I mean, you can probably go in order of numbers, 3 before 4, but I think either one of them can present.
Okay. All right. Let's go with group 3. So I'd ask the recorder for group 3 to please share their screen and take us through what you did.
Were we group 3, Linda or Michelle? Does anyone know?
Yes, you are.
Oh, I am. Okay. All right. So this is Rachel Richardson, and I'm with the Department of Learning Health Sciences, but fairly new. So this is my first workshop on this. And I've really enjoyed this exercise. We did our best. This is easier said than done. But let me go ahead and share my screen. Can everyone see this? Mm-hmm. So we had a really small, but diverse group. So I'll give sort of a summary and then ask folks in the group to just introduce themselves and comment on this. And you tell me in terms of, and certainly correct me. And if we're going too long.
Rachel, can you make your image a little bigger? Can you slide your slider on?
Yeah, let's see. Okay, how's that? Okay.
Ooh, oh, yeah. Okay.
Okay.
And that's okay. We're losing verticality. So.
Okay. No, I'll scroll. Yeah, I'll scroll as needed. And let me see if I've got my group. Okay. So we did have Linda from the Department of Physical Medicine and Rehabilitation who had more familiarity with the nursing homes that we affiliated with. So in terms of specifying a group of nursing homes, she named a few, 3 that are independently owned but have a relationship with Michigan Medicine and some ability of reporting and a shared interest in sort of the outcomes of those nursing homes that we thought would motivate them, but we also felt that the incentive was a little greater on Michigan Medicine and those providers to prevent the falls than we saw necessarily at the nursing home level. And maybe I'm over-speaking there, and that's probably not our most critical point. So we move on to our stakeholders. Certainly lots of providers within Michigan Medicine of different types. I thought that we heard that they really had an interest in understanding what happened to their patients after the handoff and to make sure that they were having good care and not aggravating or creating new injuries. Patients and caregivers obviously are stakeholders. I think the professionals invested in the care, I mentioned, as well as the people, financially responsible for the outcomes, care coordinators and managers, the nursing homes themselves, and then the nurses or staff that were closest to the patients or responsible for patient care. I'll pause there and see if anyone has anything to add to that. And then we spent the majority of our time on the data, which probably won't be a surprise for folks that know me. Lots and lots of data. We wanted number of falls, but then started thinking, well, we'd want to know sort of per shift, per day, per week. We weren't sure exactly on the unit to report that, but we clearly want to have some regular reporting in place for that. The number of falls that resulted in injury, so severe falls, and we thought sort of mild, moderate, severe, but some way to understand the sequelae, the consequence of those falls. And then additional measures, fall risk scores and complicating factors, diagnoses and things. We sort of imagine those could roll up into some clinical risk score. And then the idea that if this data were the completeness of the collection of those data, the completeness of the documentation of risk score, for example, would be potentially an important measure to just measure the readiness of the organization or the interest in terms of system solutions to preventing falls. I'll just scroll forward, and people please do interrupt if you've got questions or corrections. For data elements, this was really hard to take those measures and then think of how to divide those elements. There's the fall itself, and then the date of the fall, the time of the fall, the shift of the fall, whether those are distinct data elements or sort of attributes of the fall. We didn't get into, but we recognize there's some complexity there. The location, within the nursing home or the room, bathroom, bedroom, your door, that type of thing. And then we saw we cheated, I cheated, in terms of what we were collecting data elements around the context of the fall. So again, these could all be individual elements, but with the patient who had the fall, were they alone or were they with a caregiver in the room? Associated personnel who reported it, who was the caregiver involved? The structural features of the environment. We actually had architected design person interested in design features that was suggesting a lot of ways that rooms could be designed to prevent falls, and that how would we use the data to sort of help with designing those interventions. Also some process measures of just how well the nursing home is staffed. So how many times the nurse comes in the room per hour? What is the sort of the check-in schedule like, and how well does each nursing home adhere to that? The location of the call button relative to the patient who fell, whether water or certain, anything needed by the patient was within hand's reach, and to sort of prevent their need to get up on their own and walk if they were high risk. And then the design features I mentioned. We lumped all the clinical issues that might be a problem, sort of, medical history, recent surgical procedures, anesthesia, that type of thing, age, osteoporosis, all kinds of things. We just sort of lumped together as a fall risk that we imagine there could be a fall risk score there. And then that was the elements to focus on a few quickly so that there's time for other groups. The location of the fall we thought was particularly important to sort of help us identify potential areas for design improvement. So particularly like bathroom or whatever the location of the fall risk score, and then some measure of process infrastructure we really thought would be one to focus on. And this would be how to capture what the typical workflow or practice at each site is around prevention. And we sort of settled on either the documentation of a process, or so if this particular nursing home has adopted these bundles of good practices, identifying patients, putting signs on rooms or bracelets or what have you, that if that was documented routinely, that would be a really important data element to get. And then we thought staffing ratio might also be predictive and something that that we could capture and then look at and then learn from. And then we actually we spent most of our time on this data piece, and then at the end deciding what the kinds of things that we would like to do we wanted a process to look at the data on falls and then take that in terms of what location falls were happening most typically and really explore some design interventions. We also thought technology was important in the adoption of these well-known sort of fall prevention bundles. And I'll pause there and maybe Nate or others in the group want to elaborate just briefly on a technology intervention.
Yeah, happy to. I run a digital healthcare accelerator in North America. One of the startups that I've recently worked with is called Robbie AI. They're out of Boston. They work with commercial grade cameras. You put them in a room, you put them in rooms with patients who are high fall risks, and it actually records their bodily movement if they're actually leaving the bed, and it can actually alert the nurse well in advance for them to enter the room to help that patient get up rather than have the patient struggle, fall without the nurses even knowing. But they're a Series A company out of Boston. But yeah, there's technological advances. I feel like technology is kind of a cop-out when you're trying to focus on something internally, but there are solutions out there that can help out.
Yeah, if I could jump in here with a comment, I think part of the orthodoxy of this approach, and this kind of goes to your comment, Nate, is that what you'd want to do is choose the technology, or if you're going to use technology, to configure it in a way that makes it responsive to what you discovered from your data. Yeah. So it's not technology as a solution in search of a problem. It's technology as a solution that has a high probability of working because you know a lot about your problem because you studied it. So I think I'm just amplifying what you said. Okay, so thanks to group 3, terrific work. And Lisa, do you have a recommendation? Should we go in numerical order of your groups, or?
Yeah, I was gonna say both groups were fine. So you pick.
1. Go in numerical order. Okay, we would like Rachel, you need to unshare your screen. And the recorder from group 1, does group 1 know what their number was? Do they know their group 1?
Judy, are you there?
Yeah, I'm here. I'm waiting for my sheet.
Okay, Carrie, where are you? Yay, teamwork.
Group 1 decided that we would go with a kind of a statewide CQI model. We wanted publicly funded nursing homes in the state of Michigan that receive Medicare and Medicaid, with the concept though that the caveat that we would start small, maybe start out with 4 or 5 nursing homes and then gradually roll them in as we got better. Setting the thing up. Probably jumping into a whole state would be a bit of a jump for any of us. So we would roll them in over time. The stakeholders were many that have been listed already: researchers, patient advocacy groups, families, patients, the nursing medical staff, the PT staff, administrators for the nursing homes, maybe some IT tech support. And if there was a state hospital association might be interested, and or an organization, a state organization of nursing homes, and payers. So that's who we kind of, we roped a lot in at that. For our data, we wanted process measures and outcome measures. So in broad terms, outcome measures being, what are the endpoints? What injuries do you see? Are they injured? What level of severity of injury? We could map all that out. And process measures would be things like, did the nurses do the fall risk assessment on admission? How often do they do it and update it? What safety measures did they implement as a result of the fall risk assessment? Moving on down, We wanted to also look at things like time of day, the shift, what the staffing level was, the type of fall, was it assisted, unassisted, what location? And we also had an interest in polypharmacy in terms of how many drugs were the patients on, were there any with side effects or that maybe shouldn't be together. Policies and procedures, was a fall risk assessment done? How often was it updated? What safety mechanisms were implemented? And then basic patient demographics, gender, age, what kind of comorbidities do the patient have? Those were things that we were thinking about. And then moving on down, we kind of thought that if we could wrap up, we thought staffing levels really would probably be predictive. Maybe the polypharmacy issue might be predictive. And then just the fall risk assessment. Did it pick up the patients that were high risk? Does it match with the kind of falls we were seeing? And when you put all that together kind of at the bottom, it was really about, were the high risk patients that were identified on the fall risk assessment, were they matched with appropriate staffing levels? And did those that were highest risk have a pharmacy review for their drugs? So that's kind of what we kind of came up with our short time period.
Okay, so did your group get to the point of what you would do in terms of, what you would change if, or maybe I don't understand.
It's probably not as much as I think at the end we were a little rushed, so our intervention probably is not as well thought out. But anybody in my group, feel free to jump in. But
yeah, we had, I think, maybe a minute and a half for this intervention, but we were thinking that identify high-risk patients based on assessment, perhaps do assessments more often if they needed, if things changed, but also to maybe link them, have an intervention where a pharmacy checks for polypharmacy, see what medications they're on, whether they can cause problems with cognition and delirium, and to check that out and then see, are they having health changes that might require going to a different level of staffing within that same facility. So that's kind of where we got. It was pretty broad.
Okay, thanks. Thank you. All right. Well, thank you to group one very much. So making this even, we don't have a choice to make about the group that I sat with, but even if we did, I would pick this group. So, Greg.
Thank you very much, Chuck. So obviously we share the sense that this is a complicated thing to do. I'll try and touch on the things that we identified that were in addition or a little bit different. So we actually wanted to include nursing homes that were a group of the willing, that were interested in sharing these data, embrace the culture of quality improvement, saw the problem as their own, so more of a kind of a grassroots sense that they wanted to fix this. We wanted to pay attention to them being sort of a similar size and affiliated with a certain particular type of healthcare system and regulatory setting. We didn't specify too much, but obviously it matters if you're in the same state or the same region or the same country, and with similar funding models. And also to assure at some level that while the system size can vary, they had to have sufficient resources to be able to collaborate and participate. In terms of the stakeholder groups, many of the same, but we went through and wanted to include representatives from sort of all areas of the nursing home, including facilities workers, food service, transporters, et cetera, folks who would touch the patients in different ways and might have perspectives that would be helpful to understand fall risk, including patients and families, administrative staff, accrediting board reps, I think was mentioned, a bunch of folks with expertise in this area, the vendors who supply some of the equipment that might increase or decrease the fall risk, and not only kind of leadership representation, but also like oversight board member representation for some accountability of the nursing home leadership. If any of my team members want to jump in, please feel free. I'm just going to keep going through it, but interrupt me as you see fit. So the measurable data, how many are occurring, defining them, the frequency, the nature of them. We have some kind of parameters here. Also trying to get some frequency, falls per occupant as one way of doing it. And then the severity of them. And do you measure that by whether an x-ray is needed or a clinician needed to assess the nursing home resident, that sort of thing. And then additional measures of location, time of day, location in the facility as well. And the comorbidity that's been addressed as well. Our 5 measurable items that we came up with were the implementation of a fall risk protocol, how thorough it is and the extent that it gets implemented, monitoring for vital signs, hydration status, educating the patient about the fall risk and their participation in trying to prevent falls, time from call button activations to staff arrival. We had some discussion about sort of an AI mechanism that's already been referred to in terms of monitoring for that with video monitoring systems or bed monitors. And for the 3 of the 5 that we chose to monitor, we thought the implementation of a fall assessment protocol, patient education, and the time from call button activation to staff arrival seemed to be pertinent for us. And in terms of the design, some of this was sort of process improvement, looking at how to ensure that the fall risk protocol was occurring within a certain time after arrival, and paying attention to the staffing. Were the staff assigned to this task? Did they have the bandwidth to do this properly in the prioritization of activities? Also with the patient education protocol as well. Were there procedures for backup staffing if a call button was alerted? Was the primary staff assigned? Was there a backup if that person was occupied with some other activity at the time? And then some way to regularly and robustly share the data so that best practices could be identified or that quality improvement process could be fueled by frequent data sharing. And again, if teammates want to chime in with any other comments or adjustments, please do. Thanks.
Any comments from other members of Group 5? All right, thank you, Greg. So let me ask, I think in the interest of time, we won't ask groups 2 and 4 to go through from A to Z their work and their products. But let me ask first, Group 2, as you were listening to the other groups, can you identify some aspect of this that your group might have done differently or taken a different tack?
I'm in Group 2. I thought ours was very similar. We did choose choose to use a specific sort of corporate chain of skilled nursing facilities, thinking that would help with like some data infrastructure already being in place and help with scalability, and maybe similar pre-existing approaches to preventing and managing falls. So I don't know, that was maybe, I thought a lot of the other things were very similar. That was one thing that I thought was a little different maybe in ours.
Okay, thank you, Jennifer. Were you the reporter for Group 2?
I was.
Okay, thank you so much. What about Group 4? Did you see something different in your work, your product?
Yeah, hi Chuck, this is Jordan. So I was the
Hi,
reporter
Jordan.
for Group 4. So we identified a few items from other teams, but so like we had some similar pieces to others. I'll briefly summarize. What we focused for our intervention was to intervene on a few different levels. We wanted to have a tech component where clinic staff and the IT side would help them create an indicator in the EMR, which would help assess a patient's risk level, 0 to 3. And then we'd have patients wear wristbands with their levels. So when they're walking about the facility, visually, clinic staff would be able to know if they were of higher need. And then we also designed having a a training for caregivers and family members to work with patients in order to utilize their assistive devices and increase mobility, and in the end, to be able to help with fall prevention. That was just our high-level summary.
Okay, good. Thank you very much. I'll make a couple of observations. So the first is one of the groups, and it might have been 5, just made an important comment by the by that we want to include nursing homes that want to be part of this. And I think there's kind of a rule, to the extent that there are any rules in this business, that you don't want to conscript any organization or any individuals, for example, to participate in a learning community. So I thought that was a very important observation. And I think one of the other groups that said we were interested in a self-organizing group that just wants to do this was touching on the same theme. Something I didn't hear from the 3 presentations, but groups 2 and 4 might want to jump in if they did this. I heard it just briefly alluded to in group 5, but they kind of said it and moved on. And that is, what the heck is a fall? Is a stumble a fall? Is it like in football where your knees have to touch the ground to be tackled? Do you have to hit your head? Actually, I've used this exercise in a few times, and some of the groups really get on the web and go down a bit of a rabbit hole with this one, and they go to the CMS website or the ARC website, and lo and behold, they find there a very, very precise operational definition of a fall. And I didn't expect necessarily that any of the groups would do that, but I was struck that if you're going to get consistent measurement, and remember, one of the processes in one of the aspects of the D to K part of the cycle is to collect comparable data from these sites. So it just would seem to be very important to get every one of these nursing homes to agree on what they count as a fall. But even that won't necessarily get you all the way, because once you agree on what it is, you need a way of determining in any particular fall whether in fact it conformed to the collective definition or not. So that's particularly with your outcome measures, but with any of the variables you're going to use as part of your D2K process, since you'll be collecting typically across sites and these kinds of communities, having clear operational definitions of these often elusive concepts is critically important. I've been working with some collaboratives that are looking at COVID-related studies, and just defining a COVID patient is a similar kind of problem. And then the third observation I want to make, and I think it's really key to the intent of the exercise, and most of the groups picked up on that. If the learning cycle activity as it's structured is really dependent on driving the intervention off of what is learned in the D to K part. And none of the groups did this that I observed, but I've observed other groups doing a very human thing after they had gotten to the point where they picked their 3 variables, which they determined of the 5 would be most elusive. They kind of went, this is all well and good, but I think we should do something else. And none of the groups, it's a very human thing to do. If you really have a belief that something else is going to work, but I think it's just important to point out the script here is to drive your intervention off of what you learn from your D to K and follow the script, follow the high level nature of the script. So that's another thing I wanted to point out. So we do have a few minutes, and Nate had Yuri, you raised your hand. Where are you, Yuri?
Yeah,
Okay.
I'm right here. Thanks, Chuck. I want to just make a quick observation. I think this point about language that you're making is super important because different organizations have different cultures and language, which mean different things and kind of reflects their values. So how an insurance company uses words is different than providers, and we call them patients, they call them an expense, right? And sometimes when you try to bring these communities together, when we ask that question, right, what do you mean by that? Sometimes people get offended because the same word means a very different thing. So that's sort of an evolution of the community. And if people get really offended, the community might just disband and decide that they don't worry. So I think culture, values, and language are kind of intermixed, and we didn't put it as a specific strategic priority as a to-do, but probably I just want to say that in the communities I've been involved with, I've seen some groups just really get really upset at each other over language because then it reflects people's values.
Yeah, I think there are a lot of aspects that are important in what you said, particularly that you can't expect the diversity of cultures and professional backgrounds and a whole bunch of diversity of other things that will be reflected in a multi-stakeholder community to permit from day one a kind of coherent forward motion to begin. It's almost like these groups have to go through the storming and norming process that is characteristic of the formation of all groups. In our out-of-hospital cardiac arrest activity, we spent the better part of a year molding that community, or allowing the community to mold itself is probably a better way to say it, into a coherent organization ready to make forward movement. So depending on how diverse the learning community is, and diversity will pay dividends in the end, some sweat equity is required and time, just as you point out, to make it into a coherent, forward progressing group. Nate put a question in the chat, and from before, and I promised that if we had some time, and we do have a couple of minutes, we'd get to that question. Nate, are you still here?
Yes, I'm here. Thanks. Oh, sorry.
Yeah, go ahead with your question.
Sure. So I'll just read what I wrote, but it was pertaining to your presentation earlier, so thank you. But during your discussion, my mind often went to the general Donabedian model, which is structure influences process, which influences outcome. And then coming from like a small scale perspective, such as like, let's just say you're a singular business unit, or you're a department per se, we oftentimes come across instances where we can improve an outcome or a process, or we see an area for an improvement. But typically what I've seen is most interventions at that end of the spectrum, they're a little bit more nearsighted. They're a little bit more focused on the short term, not really long term. They're not really sustainable because there's not really a change later on in the infrastructure, as you often referred to. But if you are this singular business unit or this department, and let's just say there's a lot of variables out there that really constrain your ability to innovate or change processes, how do you effectively implement this learning system mentality or learning system type of change to adjust the structure without creating this sort of experimental sandbox where obviously there's not a lot of room for iteration, or there's not the funding, there's not necessarily the time, there's not necessarily the personnel, but how do you go about actually changing that within that unit And then how do you actually do this, like when you're trying to deliver this upstream and build it further out at scale? Does that make sense?
Yeah, yeah. It's a big question with a lot of with a lot of answers. But you know, there are some push and pull issues here that are very important. Obviously, the larger the scale of the learning cycle and the community, thus the community that's going to drive it, the more diverse it's going to be, all things being equal and multicultural, going back to Yuri's comment. But because of its diversity, there'll be more sort of self-correcting potential in it. And if things are headed in an unproductive direction, it's more likely that somebody will sense it and have the courage to speak up and say that's happening. On the other hand, the smaller the scale, the more agile it is, the more rapidly the cycle can cycle, but you may not have the diversity that is necessary to make the group sort of self-regulating. The group will be more dependent on external evidence because the scale of what is learned from the D to K will be smaller. I think you have to manage these cycles differently depending upon their size. This really dawned on me based on some of the comments that were made today. I think it's one of the reasons these networks have become so popular, and that's because a department or a division within a department can team up with colleagues at other institutions at that level of scale. You put them together, you get that. You get that diversity, but the level at which within any institution the participation is taking place is at the level of a smaller unit. So that's a way to kind of have it both ways. And I think that's one of the reasons why networks are becoming popular. They've always been popular, even more popular these days. So that's three of probably 96 things I could say in response to your question. The three things that popped up in my mind. Okay, okay, Judy, we'll give you the last word here.
I wondered if you could comment about learning health systems in relationship to benchmarked data. I'm in a collaborative of trauma centers, and we find that open sharing of the data, if you're the crummiest trauma center on a process measure, it really stimulates you to want to improve. And I wondered, is that particular only to a collaborative, but other health learning systems don't have that kind of benchmarking and collegial competition to be the best? Does that make sense?
Well, networks do. Whether they compare themselves to an external benchmark or compare themselves to each other, that's kind of that very
That's the idea.
I was talking about.
Okay.
Before, if you're not part of a network and your value on some index is 2.3, you have to look outside.
Yes. Okay.
And hope that other people are measuring that same thing and measuring it the same way.
Same way.
In order to make that 2.3 meaningful. If you're in a network and the network is working well, then that 2.3 reflects something that all the others are measuring, and you can compare your 2.3 to their values and try to draw some conclusions based on, as we did in the exercise, data that experiences and data that derive from these other sites, and collectively figure out how to improve for the benefit of everyone in the network. It really is a data-driven process. Yeah. And I said discovery at all stages is it, even in the implementation stage, you study the implementation. And so the community is always asking questions, is always discovering, it always comes down to data.
Yeah.
At the end of the day. Okay, well, thank you, everyone. It was a pleasure to spend some time with you. I hope you benefited from this experience. Thank you for your creative work in the groups. I didn't know if you expected to be put to work when you signed up for this workshop, but you were good sports about it and did a good job. So thank you again. If you do have any questions, please write to me and I'll write back to you. Take care. Have a great rest of your day, everybody. Bye-bye.
Thank you.
Thank you.